All right. Hello, Kushe. Welcome to the State of Salone Women's Health webinar. We want to tell you now, thank you for joining me today. We want to thank everyone watching online and live in Sierra Leone at Rise Radio and Strong Girls Evolution. So now, thank you. My name is Khadija Kamara. I'm a public health practitioner and business strategy consultant. I'm also a proud Salone woman. We have an exciting discussion planned for now today. You're not ready, because me are ready. Salone has had its challenges in building better, some internal and others consequences of global phenomenons like COVID and Ebola. However, women have experienced gender-based challenges apart from the threats facing the average Sierra Leonean, like malaria and typhoid. In today's discussion, we're going to talk about different things, but some of the things that we'll touch on are Salone's alarming maternal mortality rate. We'll also be discussing how the health system is in its current state and how its efficiencies and or inefficiencies are affecting women's health. Lastly, we're going to talk about health laws that are in Salone, laws that apply to Salone, and how they're affecting Salone Umande. We not just want to know what's in bad. We want to know what the challenges are. We want to identify them, but we also want to know what are the solutions. And our panelists will be touching on that. This is really essential considering the election is June 24. So not that far away. Moderating today's discussion is Eunice Mustafa, Jonta Kamara, and Fatu Amara. Eunice Mustafa is a health lawyer who recently graduated with her LLM from Georgetown University. Jonta Kamara is the founder of JontaCam, consultant and MPH holder. Fatu Amara is a health project manager and Watson Fellow. I'm going to give the mic to Fatu to begin introducing our panelists today. So Fatu, go ahead.
Thank you so much, Khadija, for that introduction. So we have 4 incredible speakers with us here today, and I'm going to start with introducing Dr. Bintu. So Dr. Bintu is a pediatrician who's also completing her PhD at the University of Bristol. She's a public health specialist and independent consultant at the Institute of Gender and Children's Research. Dr. Bintu's research focuses on children's health and sex trafficking in Africa. She's published books on COVID-19, malaria, type 1 diabetes, and helping children learn about these diseases. We're so excited to have Dr. Bintu here with us today.
Wonderful. So our next panelist we want to introduce is Miss Fatima Mahawa Sandi. Ms. Sandi has over a decade of experience in public sector financing and procurement, including managing investment portfolios for the World Bank, DIFID, ADB, and others. She's also the founder of Nayali Foundation, an organization supporting women with social and mental resources to promote well-being. She holds a master's degree in procurement logistics and supply chain management and a BA in economics. Thank you, Ms. Sandi, for being here.
So our next speaker is Dr. Hajar Ramatulai Wuri. Dr. Wuri is a multidisciplinary researcher with over 10 years of experience in health system. She generates research evidence for gender, equity, social justice, and inclusivity. She's also a senior lecturer at the College of Medicine in Sierra Leone, and she's one of the prestigious awardee of the Kofi Annan Global Health Leader Fellowship at African CDC. We're so excited to have Dr. Wuri here with us today.
Last but definitely not the least, Ms. Fatmata Sori. Ms. Fatma Sori is a barrister and solicitor in Sierra Leone and attorney in the state of New York. She holds a master's degree, an LLM, in international comparative law from the George Washington University, and an LLB from the University of Sierra Leone. She's also a women's rights advocate. She's the managing partner of Sori and Bangura that offer a full range of services in civil and criminal law. She's the immediate post-chairperson of Legal Access through Women Yearning for Equal Rights and Social Justice, Lawyers, an organization providing pro bono, free legal services and support to vulnerable women and girls who have been the victims of sexual and gender-based violence. Thank you, Ms. Sori, for being here. So as you can see, we have a lot of Salone excellence on this webinar today. If you have any questions, we'd like for you all to enter them in the chat. We will address your questions towards the end of this webinar. We also have a hashtag #DSaloneWeWant, DI Salone We Want. So you can use that on social media to ask questions. But right now, I'm going to give the mic to Eunice and Jonta to get this conversation started.
Thank you, Khadija and Fatu, for those introductions. So we're going to start off by discussing women's health. And so our first topic will be women's health. So as we know, women's health is such a large topic as it pertains to gender-based violence, maternal mortality, teenage pregnancy, and FGM, which are all issues faced by Sierra Leonean women. Various actions have been taken, especially for sexual and reproductive violence, such as a 4-month state of emergency against rape and sexual violence, several sentencing for convicts, and we've also seen the launch of the Hands of Us Girls campaign. So our question to the panelists is, what 2 issues do you see the most pressing for women and girls? So we can start up with you, Mahawa.
Good afternoon, and thank you for having me, ladies. And thank you for the question, Jonta. So first, I think it's important for us to note that health is a human right concerning each and every country. And in Sierra Leone in particular, we tend to have the worst indicators and data when it comes to women's health. And from the list that's stated there, I mean, each and every one of those issues are quite pressing, but the 2 that truly, I believe, should be discussed and addressed soon enough are maternal mortality and teenage pregnancy. And these 2 are obviously very interlinked and goes hand in hand. And as you guys rightly stated, maternal rates really, it's 443 per 100,000 live births, as stated by the WHO, which is quite frightening. And child mortality rates of 122 per 1,000 live births. And infant and neonatal mortality stood at 75 and 31% per 1,000 live births, respectively. Total fertility is estimated at 4.5%. So just giving out the data to really understand why these issues are quite there and should be addressed and looked at closely. And teenage pregnancies, unfortunately, at 21% of women ages between 15 and 19. When you think about it, 15 is still a child. And for them to have to go through the process of childbirth, teenage pregnancy is an issue that I do believe we need to, again, pay attention to and find solutions on how to tackle that. Like you rightly stated, the Hands of Our Girls campaign has most definitely made a difference and created an impact with, in that sense, protecting girls as best as possible and with the law that's been put in place as well. And also we, some of the current and previous efforts really that government has put in place, I think probably we should bring that up next as the next questions, and that the first question are the present issues. But those are 2 issues that I do believe we as a country, we as a nation, and also it's a bit of a global phenomenon as well that we should really pay attention to. And in Sierra Leone in particular, infant mortality rate and teenage pregnancy are 2 pressing issues that I do believe once those are tackled, we could probably make a difference, and we could see a quick impact in ending that or bringing a decline to that.
Thank you, Mahawa. Next up, we'd like to hear from you, Haja, on what you believe are the two most pressing issues for women and girls in the country.
Thank you very much, and good afternoon, everyone. Many thanks to the organizers for having me here. So I think all the issues that you have highlighted in your introduction, Janta, I think these are historical, they're not new to us. So I'm going to give my response from a slightly different angle. I'm not going to pinpoint what I think the two issues are. I think I'm going to try to look at what I think the underlying factors are. So as you know, Sierra Leone is a country is rich in culture. We embrace our cultural practices, but then some of our societal and gender norms are quite harmful, and they can create, sometimes unintentional, a platform for these issues that you've talked about in terms of teenage pregnancy, gender-based violence, maternal mortality, and so on and so forth. It creates a platform for them to persist. What we know what the problems are, and we have developed policies, but then we need to ask ourselves, how gender sensitive are these policies? And what do I mean by that? So despite efforts to promote gender equality, the reality is that most decision-making spaces often do not capture the voices of women. We've heard of panels even in the international space. There's a huge pushback against panels, so panels where it's heavily dominated by men. And the meaning of that is that the lived experiences of women are not captured in these policies. Yes, I'm very mindful that this is not an overnight process, but we have to be intentional about bringing the much needed change that is needed in that regard. Only then can we develop policies through the gender equity, social justice, and inclusivity lens. So it goes beyond women, also the vulnerable groups. We don't talk about the disabled as well, and we're talking about universal health coverage for all. It means for all, including vulnerable groups. So only then can we develop these policies that in turn will be gender transformative. And what I mean by gender transformative is that they're informed by context-specific evidence, and they aim to address gender inequalities and transform existing gender norms, roles, and power dynamics. And also they challenge and also restructure some of these underlying social, economic, and cultural factors that creates a platform for gender disparities to thrive upon. And then harmful gender and societal norms can also affect implementation of these policies. Yes, we can develop these gender transformative policies, but when it comes to implementation, they're often implemented through the lens of harmful gender and societal norms. I'll give you an example. Recently, the Ministry of Health introduced a community health worker policy. And as we know, community health workers, their scope of work is largely centered around maternal and child health. And the intention of the policy was that there'll be more women recruited as CHWs. And there was a financial incentive attached to this role. But then when it came to implementation of this policy, you cannot put yourself forward for a position where you're getting paid when you have a male head of household who does not have a steady income. So it created unintended consequences where in the first instance, we saw a lot more male CHWs compared to female CHWs. So therefore, we need top-down and bottom-up approaches to challenge these harmful societal and gender norms. And this will include, it's a multi-sectoral approach involving the government, community engagement, because you have to engage with the communities to ensure that when you translate these gender transformative policies, there are no unintended consequences. We also need capacity building and collaboration with local and international stakeholders. So that's just my take on it, looking at the underlying issues. Thank you.
Thank you so much, Haja, for sharing the importance of looking at who's in decision-making spaces and also highlighting the topic of manuals, which has also been come up in the World Health Organization that just happened. So now I'd like to move on to Dr. Bintu. We'd like to hear about you and what you think are the two most pressing issues in the country for women and girls.
Listening to you, listening to Fatima and Haja, and understanding what women are going through. Health in general in Sierra Leone is an everyday crisis. It's so hard to pinpoint on one. It's like there's never-ending blaze that we need to put out. And so SGBV, of course, gender-based violence, but all of these are rooted in how we see women, in our customs, in our traditions. And as Haja was saying, in the spaces that women are allowed to enter, we have a 52% population of women in Sierra Leone, and we basically are less than 20% of elective or appointed positions. We're just not there. And we're not even talking about the country as a whole. Let's talk about the Ministry of Health, because this is a health-focused panel. How many positions in the Ministry of Health? How many program managers? How many directors are women? Even in the reproductive, okay, let's go even down, even smaller, to the reproductive health and child health directorates. Who are leading these programs? They are not women. Our voices are not there. And so that means health every day for ourselves and our children is a crisis. We are always negotiating. We are always trying to find a way to make sure that we are seen, that we do not die. Because when we talk about health, about women living, it's about death and life and morbidities. Women, we hear about fistulas, and it doesn't come up because we are always measuring maternal mortalities. We are not measuring things that don't kill women, but actually debilitates them for life. And obviously, when we talk about reproductive health, we don't talk about infertilities and the abuse surrounding women who are believed not to be able to have children. So it's also interlinked, it's also pressing. Every day in the life of a Sierra Leonean woman, our health is in crisis. And as we go through this discussion and we unpack some of these things, I hope we can see how they all are. I don't even like talking about FGM, because why are we even talking about FGM in 2023? Why don't we have laws against FGM in 2023? It all comes down to how women are viewed and what our voices mean. And they really don't mean much. And so for me, everything is a crisis at this point. And we just hope that going forward, we understand that, and because it's the same structures, we need the same structures in place to end teenage pregnancy, to end SGBV, to reduce maternal mortality. So how do we ensure that these frameworks are really inclusive, as Haja was saying, very inclusive of everyone? Just because we're here, just because we have the degrees and everything, does not mean we know everything. The woman in the village knows exactly what she needs. So how do we get her voice on right here to be able to talk about what she needs, and we meet them halfway? So I think that's just what I have to say. Thank you.
Thank you, Dr. Bintu, for talking about fistula and fertility, as well as the everyday issues and the importance of also meeting people at the community and ensuring that policies are inclusive and bring everyone to the table. Next up, we'd like to hear from Ms. Fatmata on what are your two issues that you see are the most pressing for women and girls in Sierra Leone. Give you 1 second, you're on mute.
Hi, can you hear me now?
Yes, perfect, thank you.
Yeah. Good afternoon from my end. I've heard from the three speakers, and there's so much to unpack from what they've said. I unfortunately cannot narrow down the issues to just two, because the issues with women are multifaceted, of different dimensions, and are very crucial to our well-being and existence. What I see here is we've unpacked, we've highlighted social-cultural issues, and we have a mindset crisis. We have behavioral issues as well. And we have a situation where the issues affecting women are not new to anybody. And we know that issues relating to maternal mortality and infant mortality, there has always been a topic for discussion. The problem we have is not having the issues addressed. And why aren't we holding our leaders accountable? Because many a time they make fanciful speeches and promises that they never keep. And it's the very reason why our numbers are very high. Our health and safety and well-being requires investment, monetary investment. Why aren't we putting our money where our mouth is? And it's a situation where if we want to hold our leaders accountable, we have to follow them. We have to listen to what they say and remind them about their statements, because that is crucial. If we never remind them about their statements, we don't know how to hold them accountable. And even though we see the numbers coming now, one case is too many. For me, if I even have to talk about the laws and how the laws operate, we will see that we have dimensional issues of various dimensions. If we have a situation where in Sierra Leone abortion is criminal in all aspects, and I've seen a situation where even doctors are confused in certain circumstances whether to perform abortion, and society knows that abortion does occur. But every time we want to speak about abortion in its raw sense, people don't want you to use the word abortion, they want it to be controlled. And I've heard the conversation about man health, and even when you talk about this man health, it's not just about man health, it's about our institutions being all male dominated, making decisions for women when they don't know the issues that affect women. And as such, we have the crisis that we find ourselves in. We will have to understand that the government has an obligation to provide health and safety for women and everybody generally, because it's a human rights issue. But are they doing it? Do we have the adequate facilities? Do we have the good number of doctors as against the population for the health issues? Are we paying attention to the sexually reproductive health and rights? Are we paying attention to to SGBV? Yes, we've had a lot of situations where SGBV has been in the front, but when was the last time we had the statistics on SGBV to actually understand what's still going on? Since 2018 to now, we don't have the statistics and the data. And so when we're talking about all of these things, all of it comes to play. We have to talk about child marriage, because a good chunk of the people who still die are teenagers, and teenage pregnancy comes. When you look at the statistics of teenage pregnancy, most of them are already into marriage and they're underage children. Are we really protecting our children? So these obligations, when we go out there, our leaders go out there and make statements and sign to all these fanciful international documents, and then they have to report every year. But when they come back to domesticate, they cherry pick what they domesticate. They have not really dealt with the Maputo Protocol as a whole. They haven't dealt with the African Charter on Human Rights as a whole, but we're all parties to all of these instruments. So we have to deal with our health issues as women holistically. We cannot, because if we start pinpointing them to one or two issues, then we're doing a disservice to ourselves.
Thank you so much, Mrs. Sori, for that contribution. Now, make we talk small about belle woman them, where they die in a salon. Important for members say salon they among the top country them in Africa. Usai belle woman them they die beaucoup. Inside 2020, this rate dropped by nearly 60%. But one Pawi maternal death surveillance and response annual report make we know say people them they afraid for talk where belle woman die because they no want trouble. As a lawyer, Mrs. Sori, how you think say we go able effectively develop and implement maternal death surveillance and response mechanism them na salon, and use policies them way they promote community and health facility engagement, taking into consideration all the things them we just don't share with we.
So, if we're talking about policies, and government gets a lot of policies them where you look them on paper, they're very, very good. The problem we get is usually with the resources. And if you talk to government officials, they'll tell you they don't build plenty of hospital, they don't build clinic, they don't build community center and all the rest of it. But when you build the health clinic and the community center, they get what they need for letting them carry out the functions, for letting the doctor then carry out the day-to-day activities, for letting the nurses then perform their duty. I don't think so. That is where the problem is. The problem is resources and commitments. Because I remember when we went to Kenya, there was a declaration that was made by the Honorable Mr. Dr. Francis, saying they were going to commit 1% of the budget to maternal mortality and to eliminating child marriage, family planning, and all the rest of it. But when you begin the discussions around family planning and all of these things into the public, most of them take it as an issue that is sensitive, and or if it's close to the political period or it's politics. And the life of every citizen is not politics. It is a situation where you listen to people and you hear them out. So surveillance requires investment. Whatever we do into the health sector, it requires investment. The health sector is a situation where I would say it's run down because, quite honestly, every Sierra Leone we get major crisis health-wise, and if anyway for go overseas. We hear people crying for support for send Pekin and go India for health crisis. It's the same way where woman get belle at salon. Instead of it be a celebration, people are wondering, say this person we don't get belle, it go make through this pregnancy, and that not for be the case because already as belle woman, you get so many challenges for go through with your body. Your body is already challenged to carry a baby into this world, yet they go with the psychological trauma of saying, am I going to make it through this pregnancy? And me on case, I can say one, death is too many. If you go to Aberdeen Women's Center, when a donor operated entity, not a government entity, donor operated entity, if full up with underage Pekin, we don't go through pregnancy, born Pekin, and then they suffer some kind of damage because their body not ready. So why, for instance, we need to, first of all, criminalize child marriage? When we know, say, teenage pregnancy is the problem, but we're not criminalize child marriage. Why aren't we dealing with the issues of gender-based violence and rape where they result in unwanted pregnancies for people then, and where they say, no, if you get belly, go born her? Because that's basically where the law say, whether they rape you or not, go born her. Why aren't we actually putting enough money into our healthcare system so that I don't have to think to run away to Ghana or to the US or to India for medical help? Because not to all Salone man able for fly, go overseas. Not to all Salone man able for take boats, even the ferry for Costco Lunge. So we get go back to the drawing board, and when we go back into the drawing board, the men should not be in control when it comes to women's issues. Because as Dr. Bintu said, that woman with the upline, you know what in an issue. You know how to address them. And don't forget to know granny the way they upline, and we grandpa or people the way they upline, they don't use for do, they do delivery for themselves. Some of them don't ever go during some pregnancy, they don't ever go hospital. We try to discourage that. But if you get a hard to reach area, you put a clinic there, doctor not available, the nurse where they you're not too sure if he get the necessary qualification, or the nurse not get PIN code, so he never get salary. So how do you do health surveillancing when the health worker for they in a proper state of mind for provide service, not they in a proper state of mind there, because he not gets the tools where he require for let it. It's the same thing where you say the budget allocated to family support unit of the police. If you look at the state of SGBV in Sierra Leone, family support unit of the police, not for they get the amount of money where they get for months from the budget. It's to be a serious issue because SGBV and domestic violence and rape is on the high. It has not reduced, I will say that. If it don't reduce, we don't see the statistics. The reason why when they hesitate, and as of 2019 to now for publish the statistics, is because the numbers are not encouraging.
Wow, like so many things therefore unpack from that statement where you just don't make. And just like you say, it will be really, really nice if we start to embrace people and live it, experience them more, especially the women and other communities them. And also in terms of dealing with the roots of the problem, Salone gets this gloss approach wherein we get this camouflage way for dealing with issues there, and we know they go to foundational causes where they make it can be very difficult for get impact them. And as you rightly stated, without adequate resources, we not really go able to create the changes them where we want to create. And for make we see changes, we need to move the policies them from paper to practice, and we need for stop for turn woman them issues them as political tools them, because these now lives them were very, very important. Now thinking about moving from promises to practices, thankfully we get the Deputy Executive Director of the National Investment Board, and back to you, Mahawa. How you think, say, we go able to invest more into woman them health na Salone for make Salone be a self-sufficient country in that regard?
Thank you, Nafisa, for the question. And again, good afternoon, everyone. And thank you to the panelists. I mean, Fatmata, always listening to you really bring out the real issues for women in Sierra Leone. And you speak with so much passion that you almost can bring people to a point of a state of an emotional space, like, really, are we this bad? But Nafisa, Sierra Leone at the moment, really, they don't make a bit of strides towards investment in the health sector. So, for example, Sierra Leone launched the Universal Health Coverage Roadmap, which, to the benefit of us, and we should be proud of. Now, we're not the second country in West Africa we actually don't finalize the process, and the first for do so without an external consultant. So that itself, a small step, but a small step in the right direction for the betterment of women's health in Sierra Leone. And rightfully, as soon as states, definitely Sierra Leone not yet able to attain the 15% Abuja Declaration, but we also get for recognize, say, we don't see a decline because of a shock. I mean, the COVID-19 pandemic really threw a shockwave globally. And for example, in 2018, we were at 7%, and then 10% in 2019. In 2020, we begin to see a rise in 20%, and then a decline back to 10% in 2023. So this is something where definitely governments most certainly understand that. I mean, again, health na human right. It's not human rights concern what we need for take seriously and importantly. And currently the out-of-pockets, they're about 52.3% as per the National Health Study of 2020. And despite the decline, we definitely see, say, the percentage still that indicates, say, there's a really, really high catastrophic health spending. And the government don't commit to the universal health coverage by 2030. And the launch of the universal health coverage metrics, financing metrics, not a step towards that way governments don't take. And one of the ways truly that I believe Sierra Leone will able kind of supports this health crisis, especially the out of pockets for women. I mean, because again, we have to understand, say, women, like where Dr. Bintu states, we're 52% of the population, but we are not in spaces that we should be in. We are not financially capable. We're not financially independent. So we really just, and most likely where women get belly or medical issues, the man them not can always step up for be supports, because they also get this belief, say, oh, government hospital there, we're gonna have hospital that will take care of you. But it's a myth that we also need for probably do a better education for the men as well. But then when the government, then they work on implementing the insurance scheme, which I believe will drastically reduce the out-of-pocket spending, and it will increase access quality to quality healthcare services. Because again, health is a human right, and everyone, men, women, children, we all should have access to healthcare services at a reduced rate and an affordable rate. And also important for we note, say, one thing there for make you get the money for pay for the services, but it needs to be quality services. Because if you then go to a hospital and you still not get the quality treatment or care we're supposed to get, it's almost a double effort. And like where Fatmata rightly states, oh, my get Belena Salone, oh, man, they want you, they got help and born, this, that, and etc. But also, where, God forbid, something happened to, we were able to afford them. The first one, okay, let's go get a first, but let's get second opinion. But how many people in the population can really do or even think along those lines? And we can always sit down and say, oh, this person here just don't die. Oh, somebody died, they say, hey, that he died. But what's the fundamental? What's the root of that? This person a pressure patients, like what is it? So I do believe that, I mean, as far as health financing is concerned, governments make a tiny stride, but we'll surely get there. with the processes that have been put in place and the systems that have been put in place to implement. And Afisa, like you stated, it's not about creating these policies. I always say one thing we have in Sierra Leone, we have the laws, we have the policies. However, how do they become realities? How do we move from a beautiful piece of documents to actually implementing it for the betterment and for the people of Sierra Leone and the beneficiaries? And I think that's where the gap is, and that vacuum. How do we close that vacuum? It goes back to the people that are implementing it. If you're discussing reproductive child health and it's been run by men who, yes, I mean, it sounds good, but they don't really know it. They haven't experienced it. It's not a major concern for them or to them. But in an event where there's a woman leading this who knows that me don't experience this, me pikin go experience this, me mama don't experience this, it's a different kind of effort that's been put in that. So really what's important is having women lead in certain spaces or be at the table to really partake in these conversations to ensure that we move from potential to reality and just actualize what we have on paper that always reads well. And like, for example, when I can do, let's say, any kind of a review, the donors and what have you, because it's on paper, it looks good. So you always get ticked. You always get you tick off something off the box. Okay, they have a system in place. How is it implemented? It's not really what they're concerned with. So I think these are really issues that we have to focus on and focus more on. How do we as women also find ourselves in these spaces? Let woman business be woman business. Like, how do we get to that point outside of financing it? Because whether government finances 28% of its budget towards healthcare or towards women affairs, if a woman is not part of that decision-making process, we will continue to have these conversations over and over again because the interest is not necessarily the same. Yes, there are some men who are, he for she, women for women, that are fully there to protect and push women issues forward. I mean, like we've seen, the president has signed the Giwi Act. So he's a man that's really for women, into women, and cares for the well-being of women. But does that mean it translates to the people that are actually implementing some of these policies? No, not necessarily. So as women, besides having the financing or access to finance, we also need to be at the table and at these decision-making spaces, because health is a human right. And if it is a human right, women's health should be paramount, being that Sierra Leone continues to have the worst indicators and statistics for maternal health. So we need to ensure that we change that narrative by ensuring we have the right people at the table, including women, that's beyond the 30% even, because it's a crucial and critical area that we need to be there to ensure that we move things forward.
Thanks so much, Mahawa. You shed a lot of light on looking at our health system in terms of donor financing and as well as the health financing report. So when we talk about the health system in general, we know that in 2010, there was a free healthcare initiative, which was intended to provide free healthcare services for pregnant women, lactating mothers, children under 5, and Ebola survivors, which was added after the Ebola outbreak in 2014. So our next question is to Dr. Bintu and Aja, which is, what were some limitations that prevented the Sierra Leone public from benefiting from this free healthcare initiative? And also, as we look into establishing a universal healthcare coverage and ensuring inclusivity in terms of services being provided to the whole population, how do you think this should be implemented to ensure that it's successful? And we can start with you, Dr. Bintu.
So starting with the free healthcare initiative, for me, that is the best thing the last government did. I am really in support of it because I feel like, say, now the one thing and the way they come with, we really try for reduced maternal mortality, and it did. Studies show that it actually did. It reduced the maternal mortality. It actually show in the data, and people, they actually one time, then be lekam, then come for everybody come for as they say, well, woman get below man, they try for fly out. But me can say, now the kind sick way me tonight, they fly out. Salone, a lot of people then just they live on vibes and inshallah, and enough for biso. So we see the free healthcare. As much as the government's will be there, it was driven by donors. It was donor driven. And there were a lot of lapses. first of all, somebody when they talk about equipment, how you they build hospital, you say na the woman then they go born, blood bank no dey. Like how blood bank no dey, usai woman and picking and they go. So as we they think about the free healthcare initiative, which I fully support, but a lot of lapses been the inadequate finances. Where woman in Kana hospital, they say, oh, this woman, yeah, so the nurse don't ask her for money because there's actually nothing. I worked in those facilities. I work in our hospital just 6 miles from Makeni. Makeni, they get 24 hours light at the time, 6 miles from Makeni. Oxytocin all day, where they can say pepper injection, where they help the woman for, if the woman they delay in labor for help and push, ain't not been there. The woman in man there for sit on a bike, go inside Makeni for fena, whilst that woman they try for Bondi picking. So when we talk about the thing the way we need, where woman they need, WHO get all their list of emergency drugs. We don't have emergency drugs in Sierra Leone. We not get, Salone not get emergency. Person go literally then a corner to the conversing, people then they run, they go and fend diazepam. How do we save lives? So if woman then they can, and people don't trust the healthcare system, and I say rightly so. How can you trust a system when you come, there's nothing? Then tell you say, bonati no, you get for go by. How can you trust that system? Where posse come, it can die. And the free healthcare initiative, something where I notice is, it be for pregnant women and lactating mothers, which is amazing because 1 year after delivery, women are still at risk of dying from pregnancy-related issues. So covering women who are still breastfeeding it's good. But what about the woman that lost them picking them at stillbirth? At the start, Fatima gave a lot of statistics about neonatal deaths, children who die around the time of birth. So whether woman come with a pregnancy-related complication, but it not get picking, it not they breastfeed, it not fits into that category. Even the doctor, they not even know if them for charge them or waiting for charge them or how for charge them. So there's a lot of gray areas in the policies that need to be actually, put properly, make everybody understand, make it then at the world, make we know waiting with the charge for. Woman we get miscarriage, we come we need post-abortion care. Is it supposed to be free? I don't work in a cottage and we all, is it supposed to be free? Is it a pregnancy related issue? They say, oh, na bele go, but no, not a bele go well. He actually lost the baby. Is it covered by the free healthcare initiative? So we get for look at waiting a cover. We get for understand waiting the inside the free healthcare initiative. And when it comes to the nurses, then they try, UNFPA, Seed Global, they're trying to train midwives, then train about over 100 a couple of years ago. And midwives can deliver over 90% of babies. They can save over 65% of lives. They are essential, but they are underpaid. How you not go pay? How you go say me staff volunteer for 1 year? How can you even say that? So they are underpaid. They are overworked. Of course, they are demotivated. I know they go work outside and then they pay me properly, but people then just get for work. But when they go work outside and they pull you a mat, that party mommy and everybody. So when there's a free healthcare initiative, we get to understand the quality of care. Somebody talk about the quality of care, respectful maternity care, patient-centered care. We come brad and all man sit on our room, one nurse take all my blood pressure, they give all man the same message. Everybody the message different. That woman we get diabetes, we get hypertension. A message supposed to be different. So the free healthcare initiative for me now for go back to the policies and see what we need for expand. See what else do we need. We don't have the equipment. Some hospitals then they now malaria and what they are not even able to get into all waiting and not even able to do. So I love the free healthcare initiative. It was an amazing initiative. It was a good foundation, but it's time to build upon it. It's time to expand it. And governments don't say that they finance, let them finance, and also let them tell us where's the money coming from. When we know, say this money where they come now for maternal mortality, then we can challenge them. This money where they can have for woman business, not only the general health sector. Yes, 23% day for health. Also 1 day for woman business. Are we going to tax all the alcohol coming into the country or all the cigarettes? All that money where they come from alcohol and cigarettes, is it going to women? Where is the money coming from and where is it going? And again, other than they at that table, they for make sure say their allocations, then they get where they're going. So it's amazing. I love the free healthcare initiative, but we need more. And we're asking for more. Thank you.
Thank you so much, Dr. Bintu, for shedding light on issues such as the healthcare workforce and quality of care. So our question for you, Haja, especially when we talk about the health system, and especially given your experience as a health system researcher, how do we ensure that the healthcare workforce gets adequately paid? And how do we also ensure that we can uphold the quality of care provided in health services?
Thank you very much, Jonta. I think just to build upon what the previous speakers and already say, there needs to be a lot of investment, monetary investment into the free healthcare initiative. It was a step in the right direction. It was needed at that point in time, but there has to be sustainable financing. As Bintu mentioned, the reality is the free healthcare is heavily donor funded. And what I mean for that happen then, yes, the donors can come in the beginning, but then for don't get transition plan where over time, it will be then funded by the government. Then they go ensure, say, there's national ownership. So we go own this initiative. It's from the government for the women in Sierra Leone, for ensure, say, we improve continually, sustainably on we health indicators for women then. But the reality is, for now, it's still heavily donor funded. Yes, governments don't become on board, but there's a lot more that can be done. So it also links back to the investment in health. Abuja Declaration, they recommend 15%. The reality is I think we're currently at 10.8% investment into the health sector. Truth be told, even if we invest 15% into the health sector, it is still not going to be enough. So we begin to look for other ways in which we can complement waiting they happen in terms of what is coming from the national budget. It could be innovative funding mechanisms. More needs to be done. The 15% not get to be enough. The health sector as it is, there are competing priorities within the health sector. You get other programs the way they compete. So budget allocations should be based on the need. If we get a maternal mortality crisis in Sierra Leone, somebody do study on the return on the investment for lay, then they serve as an advocacy tool for sure. Say, yes, there should be more investment into this space because it has long-term negative effect, ripple effect. Even when we say we allocate 10%, 10.8%, not waiting, wait and say 10% allocated, that don't mean say 10.8% has been spent. In 2019, only 42% of what was allocated was actually spent. In 2020, only 45% of what was allocated was actually spent. So yes, I not get the data for 2021 and 2022, but 2019 and 2020 just give you an indication of we're spending less than what has been allocated. And if you take into account what I mentioned about competing priorities, so it's constantly competing as to which program is being funded within that small pot of money. And then it also has, you have to also look at the out-of-pocket spendings. Someone mentioned out-of-pocket spending. The reality for most women, yes, the free healthcare was there to remove the financial barrier in accessing care, but the reality is there's so many challenges. When you go in a health facility, the enabling environments not needed for the health workers and work effectively in terms of drugs, equipment, and so on and so forth. So out-of-pocket spending, they happen when it comes to seeking maternal care. And for most people and for most families, it's having to choose. Either we eat today or you go hospital today. That's just the reality. And that can affect their health-seeking behavior. If somebody, they say, if I go hospital and they go ask me for pay, I don't get the money for pay, why do they go hospital? So what does that mean? It changes their health-seeking behavior. Then they go in a health facility anymore. Yes, we're pushing for SALO, we get more skilled birth attendants, but then if the bulk of the women cannot afford the out-of-pocket expenditure when it comes to seeking health within the health facility, then they go other way. Then they go via the informal sector, via the traditional route. Yes, it served us in the past, but then we're trying to move away from that to increase skilled birth attendants. And then they also create a negative ripple effect when it comes to trust in the health system. If you say free healthcare, it's been publicized, say they remove financial barrier, but then the lived experiences of majority of these women is then they get for pay something where they seek care, then they don't trust the health sector anymore, which can only create negative consequences. And if you consider that in the face of a shock, we don't face Ebola in the past, we don't face COVID. What happened during Ebola, all the gains that we were making in terms of maternal health indicators, it took a backseat. It became negatively affected. Yes, we recover, and then COVID, the health system was able to absorb some of that shock when it comes to maternal health indicators. But then the level of mistrust, it's something that should be addressed. So having something on paper, which we're very good at, having policies on paper, but when it comes to implementing, we have challenges, and we're not trying to understand what those challenges are. We're not trying to put measures in place, or we could do more to put measures in place to mitigate against those challenges, to ensure that what is on paper is actually what is being translated into practice. And that would go a really long way in ensuring that the intended design of the free healthcare, which is to help in the fight against maternal mortality, child mortality, will be realized. Thank you.
Thank you so much, Dr. Wuri. The conversation actually make us think about the obligation of government, because just like how you say, not for just offer care, we need to think about the quality of care. This lead me to my next question to Mrs. Fatmata Sori. You know, Sierra Leone has ratified several charters, conventions, and protocols that uphold the right to health of women. Some of these include the African Charter on Human and People's Rights, the Convention on the Elimination of All Forms of Discrimination Against Women, or we favorite CEDAW, and the Maputo Protocol. However, we still get restrictions, even though Section 8 subsection 3, paragraph C and D of the Constitution of Sierra Leone, Act number 6 of 1991, also addresses the right to health. Nonetheless, pursuant to Section 14 of the same Constitution, that right is not justiciable, and we just consider health as an objective of the government, something where the government they work towards. Based on this background, Barrister Sori, and in the midst of existing legal limitations, how can we hold the government of Sierra Leone accountable for the poor status of women's health?
That's a huge question, Unice. You see, the problem with government is every government comes and they determine what is the priority. And all these beautiful charters where you don't talk about are parties to those protocols, to this charter, to this commission. But I will tell you, not all of them have been implemented. It is the reason why we still have child marriage in our laws. It's a legal thing to marry an underage child. If your custom permits you to marry an underage child, you can marry them. And it is the reason why I said at the very beginning that when our state officials go out and make commitment and statements in these international platforms, we get for the follow them more than they go on their platform, then they for no waiting and they go say. And we hold them accountable to the statements. Like I said, in Kenya, ICPD 25, the Minister for Minister of Environment, a commitment that they were going to commit 1% of their budget to maternal mortality, exactly 1% of the national budget, right? So maternal mortality, to reproductive health rights, and it was a very beautiful statement that he made. I chased him on Twitter to say, we're now towards the end where we start talking about budgets. I hope government is paying attention to your statement. And luckily I recorded him. So I played the recording and I put it and posted it on Twitter to say, this is government promise and it should be implemented. But as always, They make the statements, they leave, it's a fanciful statement and nothing happens. And because sometimes as Sierra Leoneans as well, we also have a problem. Our problem is sometimes we don't chase it through to the end. We feel to say it's one man's obligation to do it. Our governments make manifesto promises, they make rules and policies. You've heard about the Universal Healthcare Declaration that they have just made, the free healthcare. Dr. Bintu don't highlight the gray areas. Aja, Dr. Wu, you don't tell you about the health-seeking behaviors of the people, and all centered around the fact that government not puts preference, priority, and resources where it's supposed to be when it comes to the health sector. And so when it comes to issues like time for elections right now, so we do politics, we're supposed to ask the questions. What are you going to do to tackle maternal mortality? Are you going to deal with abortion rights? Are you going to deal with X, Y, and Z? And for me, I've been in the space where I've worked on promoting and pushing for overhauling of the Sexual Offences Act of 1864. Can you imagine? That act that says women do not have a choice to determine whether to carry or not to carry is in 1865. And then the Pharmacy Board Act says any pharmacy posting will give prescription will result in termination is a crime. But it is not that we don't know as a country, our leaders and everybody, that the abortion happens in the safest and in most unsafe places. It happens. And then we have issues of commitments that they make to family planning. Family planning becomes a situation where mostly only donor partners comes and they start giving us condoms, distributing pills, take on the challenge of educating people on family planning and all the rest of it. But when you go, you check the policy, we have a family planning policy. And I think it's Dr. Wu who said, even though the budget allocations could be X percentage for health, the one way that they use is only maybe 40% or 45%. So some of these data and statistics, we therefore defend them or use them as a weapon for say, you have not delivered. If you budget say X, Y, and Z, and you're telling me A, B, and Z, it's not a tally. But the Salone people, sometimes we get confused. There's too many things going on. The economic stuff, not the EPWI right now for when we think about mortality. So preference becomes putting food on the table today than thinking about my headache. Because if you have picking, you get picking them, you get 20,000, you they ask, you think, say, before I go buy this Panadol for that feel better, make I go buy one cup rest and cook. So the challenges of life. Go ahead. Somebody wanted to ask a question.
Oh, we lost you.
Okay. So the challenges of life make it overwhelming on the day-to-day living of Sierra Leoneans. But our laws are also wicked. I will tell you, if you go to that very constitution where you talk about, so section 27(4)(d) allows for discrimination against women in so many aspects in your family life, where they affect maternal mortality. And I tell you, when we were discussing abortion, we were in a round table where I did a presentation, and the people and they asked me, so you want to tell me, say, if me get belly? If you go to doctor, now you one day able to go to doctor and speak to the doctor in confidence. If me ask the doctor information, give me, and I said yes. The doctor then get obligation, they get ethics and a profession where they say, where you get client meet or you and patients meet, you tell what you have. Also, the man who put behind me back, or me 23-year-old picking, imagine an adult. Me 23-year-old picking will go pull belly if you get belly. So all of these. We have a mindset challenge, and that mindset challenge they make able to ask the government them and hold them accountable, because sometimes they clash with culture, they clash with religion, everything intertwined. But don't forget, our government should not be involved in all of these things. The government is focused to be the people. What the people want, what are the needs of the people? And the problem now is we know say maternal mortality is on the high. We know the health crisis stay in the space, and we know some of the issues that they result in health crisis. So most of it is a lack of resources. We're not there. So if you build community center now, then they say, oh, all these we don't build state-of-the-art hospital. If we have a state-of-the-art hospital, our man will go there for go born picking. You go smart for save you money than you go fly, go Banjul or travel, go Liberia, get good hospital at all for go born. So we have to stop deceiving ourselves with how we describe certain things. That's all our government are accountable for by their description. So when you pass your policy, don't go put you are going to build state-of-the-art hospital for we, where you know say it's not going to be state-of-the-art hospital, we're not get any machine for them going for no waiting, they're not gonna drop like for any picking heartbeat. And you say state-of-the-art. Meanwhile, other people are way advanced ahead of us, and our politicians, our government people, they travel. They know what is out there insofar as services to women, girls, children, to their sex ed. So they're supposed they push us to settle for less, which is very, very bad. But we have to hold them accountable. Even during the election, your vote matters. If the subject matter is relevant to you, make sure say the one you want to vote for. Address that issue there. Let us have the platform to question the people who want to lead us. So not every Jack and Jill can come and say, I want to be the leader. So no, we don't tie a small pan this paper, black and white. If it's black and white is not implemented, it's of no use to me. Then they get lost.
Yeah.
Thank you.
Yes. Thank you so much, Mrs. Sori. And you really correct in terms of how we were able to ensure we hold leaders them very accountable for all the statements them way then they make for ensure we follow up on them statements them they, so that anytime they make promises then for deliver, and not just about the delivery but the quality of delivery for ensure them actions them actually match with them words them. So as we try for wrap up now, we move over to questions them. So one of the questions them we get now from Hawa, where they ask say, they wonder how the state of the nursing profession na salon dey. Wetin are the resources? Wetin are the training? Wetin are the compensation wey available to we nurse them na salon? And how this specific thing them they impact the overall health situation as salon, including woman and girl picking them health them. Thank you. So I don't know if Dr. Mansari will able to answer that question.
Hi Eunice. So this one, I just a balance answer to Dr. Wee. There's no way Haja Wee they didn't I talk for nurses in that salon. So Dr. Wee, this question is yours. She was actually the dean of nursing. So this is entirely her area. So Dr. Wee.
Thank you for make remember.
I just knew you were going to say that, Dr. Mansari. Thank you very much, Hawa, for that question. I hope you can hear me. Yes.
Yes,
okay.
we can hear you.
So the state of nursing profession in Sierra Leone, a few years ago, we, believe it or not, we get a lot of nurses them than waiting we actually need in terms of numbers. But then when you look at the specific cadre of health, the type of nurse, we've been don't overproduce a lot of the wrong cadre. So we need more, the one that we get more training, but what we've been get was we've been get a lot more we just go through a shorter period of training. So some of the training institutions, the Ministry of Health, donor partners, then come on board for try for see how best they can address that need, and then create a program where they can upgrade. So if you're not state enrolled community health nurse, so state enrolled community meaning for the work in the community, but the reality is most of them you go find in a health facility. Some donor partners, ministry and the medical schools, then come on board for sale and see how they can create an upgrade program for upgrade their state enrolled community health nurses them to state registered nurses them, so they get a bit more training. And then so that but it's when you look at the yes, it's a step in the right direction. But if you look at the thousands where we don't where SCCHNs and so the state enrolled community health nurses that we currently exist, and then I think on a no more than 500 or so they upgrade in the first instance. So a lot more needs to be done. And then another issue we get within the health sector when it comes to nurses and midwives and the link to maternal health. In the past, you did do midwifery for practice as the midwife. You did train as a nurse, state registered nurse, and then you do your state certified midwifery program. And it was, you only do that, and not necessarily because you want for practice as a midwife, but because you want to let them promote you within the civil service. So having the SCM, the state certified midwife qualification, not so because you want for practice as a midwife, and because you want to let them promote you within the civil service. So again, that's another challenge that was identified. And the medical school, over the last couple of years, don't introduce a direct entry into midwifery. So when you come into the medical school for study, if you say you want to do midwifery, you get trained for become a midwife. And when you graduate, you'll be posted to a health facility where they cope with where they deal with maternal and child health issues. So then are some of the measures then we don't put in place for try for address some of the challenges then. But a lot more challenges then exist. Dr. Bintu touched on lightly earlier on about nurses not necessarily being absorbed upon graduation immediately. And we know the health sector not able to absorb them all because it has an effect on the wage bill. So I mentioned earlier about the investment within the health sector. Most of that money, the way they spend within the health sector now on the wage bill. So the more health workers and nurses are the bulk of the health sector, the more you absorb, it means say it increase the wage bill. So the wage bill will continue for increase. And that is if you only come up from that money, where then they send towards the health sector, where other things than they for deal with. So yes, some things and they don't put in place to address the problem, but there's still existing challenges that needs to be addressed. Thank you.
Thank you so much, Haja, for sharing light on the nursing profession. As we're mindful of time, I'm gonna pass it on to Fatu to wrap up. And so sorry we couldn't get to all the questions that everyone had.
Thank you so much, Janta, and special thanks to all our panelists, Dr. Bintu Mantare, Dr. Haja Ramatulai Ruri, Fatima Mahawa Sandi, and Barrister Fatmata Sori. We're so grateful for your insights and also your experience in work in Sierra Leone. This was such an instrumental conversation, and it's just the start. We encourage you to continue these conversations in your household as well as in your communities. We would like to thank the Institute for Legal Research and Advocacy for Justice for providing the Zoom for this event. Without them, we would not be here, so very special thanks to you. We would also like to thank Strong Girls Evolution and Rise Radio, who live streamed this event in Sierra Leone. Certain times when critical conversations like these are hard, it's not underground. So we're very thankful to them for bringing this underground in Sierra Leone and bringing women to hear about these conversations. On the social media end, we would like to thank Cover Girls, Sarah Kale Blog, Transformative Women's Initiatives, Ariana Diaries, and Jonta Kam for promoting this event on social media and getting so many people to hear about it. So our call to action is to continue these conversations, but also connect with us because this should not be a one-time event. It should be something that's ongoing, and for women's health to be instrumental in Sierra Leone, it's up to us to hold leaders accountable, but as well as continuing the conversation. Thank you so much to everyone that was able to join us here today. Thank you, and I hope Silna get a good weekend. Thank you.